Good afternoon, everyone. I'm Don Wiley, President and CEO at St. Joseph's Medical Center. I want to welcome you to our second COVID-19 community update. I'm very excited to welcome all of you. We have about 180 and growing on our webinar today, and I appreciate everyone joining us. This is certainly one of the few ways that you can get a great deal of information about what's going on in our county and at least at one of our hospitals, and be able to ask questions which we've accumulated before the meeting and will continue to during if you want to chat to Neeley Pettis. Today we have myself, Don Wiley, we have Scott Neeley, the Chief Medical Officer and Designated Institutional Officer for Graduate Medical Education here at St. Joseph's, and Dr. Maggie Park, our Public Health Officer for San Joaquin County Public Health, board certified pediatrician. And I'll just remind you that Dr. Neeley is an intensive care physician with 32 years experience in intensive care. Our agenda today is this quick welcome, and I'm gonna do a brief hospital update, but before I do that, let me ask Neeley Pettis to please lead us with a short reflection today.
Our reflection is, I hope we carry with us the acts of kindness we have heard of and witnessed during this time. May we remember the resilience of the human spirit and try to emulate those who have been a light in dark times. I hope we remember that our actions really do matter. When this is all said and done, let's cherish the beauty of normal. Stay hopeful, friends.
Thank you very much, Neeley. So I've got a brief hospital update today. Neeley, you'll go to the next slide. And the next one. Thank you. You may have been either seeing on the television or in the newspaper that San Joaquin County hospitals are about 138% of ICU capacity. And in fact, that is true. We're actually higher than that here at St. Joseph's. And originally, our surge plan for COVID-19 included starting with our existing 39 ICU beds and having the ability to expand that by around 49 beds. And so far, we're about halfway to that target number, where we've expanded outside of one of our ICUs on a telemetry unit, and we're also running basically an intensive care unit in our emergency department. So we've been very busy with both COVID-19 positive ICU patients, but also others. And Dr. Neeley will talk a little bit about the specifics of the number of patients and so on. Volumes in the hospital overall has been quite busy from a census standpoint, averaging around 300 patients being in the hospital at midnight every night, but with 40 or 50 patients coming and going every day, it makes for a very busy hospital, even with 355 beds. And the emergency department has been busy, not from a sheer volume standpoint, as obviously our volumes on a daily basis have come back down to about 220 a day. That's about almost 30% off of our baseline numbers. But because we're holding inpatients at any given time, makes for a very busy emergency department. Back in the first week of May, we resumed what we call deferred procedures, but every day we're evaluating what surgery could be done, especially if it may require an ICU resource. And I have to thank our cardiovascular surgeons, Dr. Tendlekar, Dr. Morrissey, and Dr. Stoll, who have really been very cooperative. They represent the majority of those ICU surgeries, and they have worked very closely with our team to make sure that we can provide safe care and at the same time balance the actual clinical needs of their patients for surgery itself. In our facility, we're continuing to require masks for all patients and staff. We continue to have significant visitor restrictions. I remember on our last call, Dr. Park said we could loosen up on those a little bit if we wanted to. We don't think it's safe to do that at this point. and we appreciate being able to blame Dr. Park for it. And I'm joking, obviously. We have a little bit of flexibility, but we think it really is not a safe environment for people to be visiting with patients over a long period of time. And we have limited those visitation to a birth coach, an adult for a child, and someone who needs an advocate in a very short term, and then end of life for a small number of family members for a short time. And we're supporting Dr. Park and San Joaquin Public Health United Way on the Mask On campaign. This is not a political issue. If people wear a mask, if they socially distance, if they don't congregate in large groups, if they stay at home, if they wash their hands vigorously and frequently, and they don't touch their face, we have a chance of reducing the spread of infection. And that's scientific fact, that's not a political fact. And I want to just say also, finally, we really have the best team of people here at St. Joseph's. Both the senior management team and our whole management team and all of our employees. I've been in healthcare for 40 years. Dr. Neeley, 32 years as an ICU doctor. And we have never seen anything like what we're seeing in healthcare today, or for that matter, outside the hospital today. And we'll get through this together, but the employees of St. Joseph's Medical Center are very dedicated and resilient, and we want to thank them. Let me turn it over to Dr. Park, our Public Health Officer for the San Joaquin County Public Health Services. Dr. Park.
Thank you so much. And great to be here again, and I appreciate the opportunity you've given me to speak. This is a slide that shows the total number of cases of COVID that have been confirmed as positive in the county since the beginning of this pandemic. And you can see that we're at over 9,000 cases as of today. The last couple of days, if you look at the new case counts that are highlighted in yellow, show that we had maybe hundreds to 200 new cases per day. That is actually expected to go up as our counting continues. If you could see, 3 days ago, we had over 400 new cases just on one day. So we're getting phenomenal numbers of new cases added on every day. Next, please. This is the same sort of slide that shows you the deaths that we've experienced from the beginning of this COVID pandemic, and we're at 107 deaths now as of today. And if you follow your eye along, you can see that starting around early week of July, we really had a big upswing, where there are some days where we're having as many as 6 deaths in one day. And I did try to give you age groups because there was a request from somebody who had written in with a question about deaths by age group. So we break it down the way the state does. So you'll see our totals there. Where we need to mask because there's less than 5, we put less than 5. But you can see how the deaths by age group are broken up. Next slide. This is something that I just took off of our dashboard, which is on our website, the percent of cases and deaths by race and ethnicity. And in the blue, you'll see the percent population that a particular ethnicity makes up for in our county. The yellow is the percent of cases that that ethnicity makes up for. And the orange is the percentage of deaths that that particular population or ethnicity makes up in our county. I wanted to let you know that this data is taken from the state, and it's the best data we have for as far as real numbers go. And you will see that if you look at the Hispanic population right there in the middle, you'll see that Hispanics, Latinos make up about 41.1% of the population of San Joaquin County. And they have a lesser amount of cases and deaths by the yellow and orange bars. But what I want to show you in the next slide, if you would go to the next slide, is that the reality is that although Hispanics don't by number seem to make up the majority of cases or more than their population, this largest bar, which is the unknown bar, the brown bar, we presume to be mostly Hispanic or Latino, because when we look at these unidentified people, Maybe we haven't contacted them yet or done our case investigation, or we haven't received their report on their ethnicity. It's a self-reported ethnicity. And what we're finding is that if you look at all of the Hispanic surnames, and we tagged about 50 Hispanic surnames and add that to the count, we believe that that Hispanics and Latinos actually make up 60% of the new cases of COVID for the last several weeks. So much more than their actual proportion in the community. Next slide. This is something that I get from our Emergency Medical Services Agency, and it's basically their tracking report of the number of people who are hospitalized for COVID, and that blue line shows the number of people currently hospitalized with COVID in our 7 area hospitals across the county, and the count right now stands at 240 people currently admitted for COVID. The red line is the number of people who are in ICUs. Out of those 240, we have 73 patients in our ICUs. 50 of those are on ventilators. Next slide. This is the total hospitalization census, so including medical, surgical beds and other beds available, not just the ICU. And if you look at the very top, it says that our licensed bed capacity across the county is that we have 982 beds. The blue line shows our hospital bed census, so total bed census including ICU, and we have currently 746 people in hospital right now, which is 76% of our total bed capacity. Although that would suggest that we have some capacity left, we really don't want to be exhausting that completely, and it doesn't necessarily mean that just because we have bed capacity that we would have the staffing to man all of those beds. The red line shows, again, the number of people hospitalized with COVID, and as I said, that's at 240 people. And although this 746 people out of 982 beds represents 76% hospital capacity, our ICU capacity is well over 100% at 132%. So we are in surge, most definitely. And these numbers are obviously worse than the numbers I brought to you a month ago, the last time I was on with Dignity, and it's kind of disheartening to see. Next slide. This is the rate of cases of COVID on week-by-week basis, so something that our epidemiologists put together to show how many cases we have in the county, and it's updated as up to July 12th, and you could see that we have really gone up high. Back in April, beginning of May, we were well below the 25 cases per 100,000 that the state wants us to be at. And we did a test around May 20th that we had stayed there for well over 14 days, and that was part of our attestation process, was to demonstrate that we were under 25 per 100,000. As you can see now, we're over 200 per 100,000. If you look at the state's numbers on us, we've been as high as 300 according to the state. This is what my uppies have put together. We had a little bit of a dip, but it seems that we're moving up again, which is unfortunate. And next slide. This is the rolling 14-day COVID case total. Again, something that the state was watching, and they want us to be at a goal of about 190 new cases in a 14-day time period. And that's represented by the green line, which is 190. For our population being at about 762,000, that's the number we were supposed to be at. But you can see that over time we have surpassed that number by far. So this is a graph showing how many cases in 14-day periods, if you graph it out, and by the things that have happened over time. So you'll see again that in April we were doing very well, and we were underneath that green bar. And then when we started to open things, the numbers just started to skyrocket. So the reason for us going higher and higher is multifactorial, but this graph shows how some of that is caused by the things that we've reopened and the events that we've had, such as Father's Day and now 4th of July, where people have had gatherings, and we do believe that that has made the numbers go up. And next slide. This is given to me by the state. The state has used different data scientists, different modelers. And as you can see, one is called COVID Act Now, another is called Lemma, Johns Hopkins, Stanford, UCSF. Different data scientists give the projections for what our R naught is. And then they have the ensemble line. And so if you look in the red bar, our R naught or R effective is 1.12. Everyone wants this to be at 1 or less, which is a sign that you're transmitting less. Your R naught basically tells you how many people can one person infect. And so you want it to be less than a 1-to-1 ratio. And the state says that at a 1.12 rate, that spread of COVID-19 is likely increasing in our county. I will tell you that this was as high as 1.32 a couple of weeks ago. So if you look at that ensemble, the darkened blue line, which is the collection of the different data modelers, the collective ensemble projection shows that we have taken a little bit of a downward turn. So it was worse before. So that's a little bit heartening there. Just wanted to share with you why we're on the state's watch list or monitoring list. This monitoring list was developed several weeks ago, and we have pretty much been on this list since the time of its inception, and we have not been able to get off of this list. And the things that the state has us on the list for, there are 5 metrics. The first one being cases per 100,000, and as I said, where we were well over 200, and currently as of the latest data, they're saying that we're at 383. The other thing that the state, one of the other 5 metrics is this testing positivity. The state wants us to have a positivity rate of less than 8%, and we're now at 15.4. And if you can see, they've put us in red for that, saying that we've gone up 1.63% since the last time they checked, and they checked with 7-day lags. And next slide. Those were 2 of the metrics, and then another metric is what is up there at the top, our percent change in 3-day average for hospitalizations. They look at how many people you have in hospital over 3 days and compare that to the next chunk of 3 days. They don't want that percentage change to be more than 10%, so they say that we're at the moderately concerning level at 9.5. ICU beds and ventilators are the last 2 markers. We have not had a problem with our number of ventilators available, but our ICU bed numbers are usually in the more concerning or very concerning areas. There's been some conflict with this number that the state portrays, because as I said, we really don't have ICU beds. We're beyond capacity in most of our hospitals, yet they say that we have 13.6 available. So we're trying to work with the state to see how we can correct that, because we actually don't know that to be true. And they were including neonatal ICU beds, and we're trying to get that kicked out of there because that's not a true reflection of the adult ICU beds that we have available for COVID patients. Next slide. Just want to show you that we're currently ranked 5th right now in the state when they put us ranked by case per 100,000 case count. So we're only lagging behind Lassen, Colusa, Stanislaus, and Marin. And we've been kind of in the top 5 or 6 for several weeks now, definitely top 10 since this list was created. So we have a high case count per 100,000 population. That's just the reality. And because of that, the state has reached out to us and has let us know that they see San Joaquin as a hotspot. And today I will let you know that we even have a new team coming to visit public health this afternoon. And that team has members from CDC and FEMA on it. So now even the federal level is involved with looking at San Joaquin. Next slide. I just wanted to show you this slide because people ask me all the time, where are the cases, where's the transmission, and what is going on? And this is a slide that tells you where our outbreaks is, but outbreaks is really only one picture, one part of it. The most of our contact tracers and our patients themselves don't know where they picked up COVID. So the majority of transmission is still community acquired, meaning it's just out there in the community. It's it's everywhere, and you don't know where you got it. But when it comes to an outbreak, these are the circumstances where we've actually been able to find a source. And the definition of outbreaks is given on this, on the right side here. This was a graph that was posted to our social media page about a week ago. And if you can see, about a week ago, we had 70 outbreaks the day it was posted to Facebook. And literally since that time, we've gone up to 91 outbreaks, which is the total number of outbreaks you'll see on our dashboard today. And so you'll see that in a community setting, such as a school or an office, church, 3 or more people having COVID within 2 weeks counts as an outbreak. Congregate settings, 2 or more people. And in a skilled nursing facility, the state has deemed that 1 case would constitute an outbreak, and that is when we need to start our investigation with even 1 case. And then if you look at the circle, you can see that most outbreaks are attributed to community, followed by congregate and then skilled nursing facilities. But this just to explain to the public what outbreaks are. We actually have lists going on as to what exact settings there are, and we have a very extensive list of restaurants on there, a bar, medical clinics, hospitals, certainly living facilities, our skilled nursing facilities. I can't give you all of those by name, but just to let you know that we do follow these numbers, and we do have places that are currently being added to the list every day, and we follow up on that. And next slide. This is quite a busy slide, but something that we put together for one of the people who wrote in asking for our total test numbers. And so the epidemiologist will break it down by week, how many tests have been completed in the county. Out of those tests that were completed, how many people had positive results, which leads to your positivity rate. Then there's the negative results, obviously, would be just the subtraction from the positives from the negatives. And then the deaths that we've had over time, which leads to a death rate that would be reflective of how many deaths we've had divided by how many positive tests we've had. It's a difficult number to give because death rates can be calculated also by the number of deaths you've had divided by the 762,000 people in the population. So it can be given as an overall risk. And I hesitate to share this number and really ask you to hang your hat on it, because there are lots of people who are in that denominator of total tests who are still in hospital right now in our ICUs and could be dying. So we don't really know what our final death rate from this disease will be. And I'm assuming that in the future, when this pandemic is well over, that we will have better numbers overall from scientists worldwide. And the next slide is just because we had a question sent in to us about children. And this is just one website that you could look at for numbers on children in the country. And the question given to us was about all the transmission studies that are being done in kids. And there's just so much to talk about there, so I might save that for question and answer time. But I wanted to let everyone know that next week on July 31st, with the UOP Beyond Our Gates people, will be doing a community council, myself and Superintendent Jamie Musalimas. So there will be more information on kids and schools in that webinar held by UOP next week. And that was my last slide. I will hand it back to you, Mr. Wiley. Thank you.
Thank you very much, Dr. Park. I'd like to introduce Scott Neeley, our Chief Medical Officer, to give an update that's more specific to St. Joseph's. And the slide breakdown is actually, I think, very helpful in terms of really understanding the seriousness of the infection for patients who are hospitalized. Scott?
Hi there. Can you hear me okay?
Yes, sir.
Excellent. Okay. Well, good afternoon, everybody. I'm Scott Neeley, and I've been the Chief Medical Officer at St. Joseph's Medical Center for almost 7 years now. I practiced most of my career in Chicago, and as Don said, I've been a pulmonary critical care physician for my entire career and have over 32 years of experience as a clinician. The slide behind me, the screensaver, says always safe, and that is our focus and our primary goal at St. Joseph's, to make sure that we are keeping our patients safe and delivering the highest quality of care. And our safety program is called Always Safe, and so that you don't have to look at the grungy wall of my study behind me, I'm giving you the Always Safe logo for the duration of my talk. I want to talk a little bit about how we have responded clinically to the pandemic and to the patients that we've taken care of at St. Joe's. And I also want to talk a little bit about those patients and what they've looked like and what their outcomes have been like. And finally, I want to talk a little bit about testing, a little bit about other impacts in the community, and finally, talk a little bit about what our view looks like for safety, really for all of us, all the patients that we take care of, all the people who work with us in healthcare, and all of you as well. Next slide, please. Okay, so I could spend probably a couple hours just talking about the changes that we have made in order to respond to the COVID pandemic at St. Joe's. But I want to give you at least a high-level overview of what that looks like in a few minutes. I think the first thing that this has represented for us is a huge opportunity for us to learn. We were presented with a disease that we have never seen before, and which is extraordinarily unique. I can tell you that as a practicing critical care physician, I have never seen anything like this. The severity of illness that some of these patients present with, as well as the diverse presentations of the disease, is just extraordinary. And I can also tell you that the demand on our critical care physicians, on our emergency medicine physicians, on our hospital-based physicians, and our nursing staff and respiratory therapists is just extraordinary. And we've had to learn essentially a whole new topic of medicine in a very short period of time. And one of the things that I'm very proud of is the way that our physicians, nursing staff, and respiratory therapists have responded to this. They have really made themselves experts and sucked up the state-of-the-art information that's coming up like a vacuum. And they're putting that into practice. They're taking care of extraordinarily sick patients, and they're doing it with incredible skill. We've also adopted a number of new safety practices at the hospital, which include, as I'm sure all of you know, universal masking for all of us while we're working in the hospital, screening for symptoms and fever, limiting visitors, increased emphasis on all types of hand hygiene, and really robust efforts to ensure that we have enough PPE for our staff. We've adopted new critical care protocols. The photograph that you see in this slide is actually a patient who is in a device called a rotoprone bed. Now, this bed can turn the patient so that they are lying on their stomach within the machine, and it keeps all of the tubes and lines and so forth that are necessary to support the patient sort of in an untangled state. So this is somebody who's receiving mechanical ventilation. They have an endotracheal tube in their throat and many support lines. It's an absolutely extraordinary contraption. We used to use one perhaps 4 times a year. At the present time, it's not unusual for us to have 6 or 7 of them in the hospital operating all at once. And that's just an example of how we have had to really up our game in terms of the intensity of support that we provide patients. We've also been able to utilize a number of experimental treatments, and I will get into that in a little bit more detail with my other slides. We have worked hard to continue our testing expansion and our ability to do more and more tests, and I'll address that as well. And then our operational responses, which again are extraordinarily sophisticated and complex. We have, for example, already nearly doubled our number of ICU beds. We're licensed for 39, and our surge plan will take us up to approximately 80 ICU beds. That means that we have the capacity and the equipment to do it. It doesn't necessarily mean that we have the staff, and we're working hard also to improve our staffing under this extraordinary demand. Next slide, please. So this is a very busy slide. It contains a lot of information, and I'll just preempt some of your questions by saying that no, we're not going to be able to share the slide deck because this slide deck contains confidential health information, and This is not the sort of information that we can share very, very broadly through the community. But what this slide shows is the impact of, Natalie, maybe you can figure out who unmuted and get that person muted. On the left, you see the number of total cases that we've cared for. So we have admitted over 450 unique COVID positive patients at St. Joe's. And that is reflected in the blue line there on that graph. As you can see, that line began to rise rather steeply in early June. And as Dr. Park indicated, we believe that when people essentially stopped the lockdown around Mother's Day and then accelerated that with an increasing number of social gatherings and a decrease in compliance with physical distancing, we began to see the current real blast off in terms of our case numbers. When you see a blast off like that in terms of case numbers, you'll hear some people talking about, oh, it's just an increase in case numbers due to more testing. Certainly more testing will tend to increase the number of positive cases identified, but this surge is not due to more testing. And the reason that you can understand, the way that you can understand that is that a week or two after the numbers start to surge, the mortalities start to surge. And those orange bars there are the cumulative mortalities that we've experienced at St. Joe's. And that number has increased very sharply over the last few weeks. That's a tragedy for a lot of people in our community. And it's a real thing. It's not something that can be polished up through reporting or manipulation of the numbers. The other information that we track on this is the age of folks who are being affected by this, as well as race and ethnicity. The vast majority of our patients are over 40, but I want to point out that there's a very substantial number, about 30 plus 32% of our patients who are actually between the ages of 40 and 60. And some of those patients are extremely ill patients. Tragically, we have seen substantial loss of life, not only of older patients, and I'm not an ageist, a loss of life is loss of life, but in many instances, we've seen loss of life with very young people who have young families and are your neighbors in this community. And it has truly been, a tragic impact so far, and we believe we're really still at the beginning of this. This dashboard also summarizes race and ethnicity. The racial makeup of our patients reflects our community pretty well, and 45% of our patients are Hispanic with respect to ethnicity. Again, representing the makeup of our community pretty well. And then down in the left-hand corner, you can see where most of our patients go when they leave the hospital. 225 patients have been discharged home. Almost 50 have gone to skilled nursing facilities. And then we've had 70 mortalities, and that number, I believe, is actually a little higher now because we did have a mortality early this morning. Next slide, please. So now we go from a summary of what we've seen at St. Joe's to what's happening in the community, and I'll go quickly through this slide as Dr. Park has covered a lot of this information, but I would focus your attention currently on ICU bed availability and the number of licensed ICU beds, as well as the fourth line, which is percentage of ICU capacity. At St. Joseph's Medical Center, we have 39 licensed ICU beds. We currently have 64 ICU patients. And so 64 ICU patients and 39 ICU beds gives you an occupancy of 164%. Now, we have accomplished that by expanding ICU beds out into other units in our hospital. And at any given time, we may have 10 to 15 ICU patients actually in our emergency department waiting beds upstairs. So we're at extremely high capacity in terms of our critical care population. And that is a big challenge for us, both in terms of taking care of these patients, but also taking care of other patients. Because, for example, cardiac surgery patients need an ICU bed post-op. And if we are well above our occupancy for ICU beds, it's difficult for us to do those very important surgeries. Now, we've been able to do the emergencies, but as Mr. Wiley mentioned, we have had to delay some cardiac surgeries in patients who really have an indication for the procedure. It's not an elective case. There's really not such a thing as an elective cardiac surgery. If a patient needs a cardiac surgery, they need a cardiac surgery. Sometimes they can be stabilized for a few days while they're awaiting their surgery, but it is essentially never an elective situation. Can we go to the next slide, please? And then this slide, again, gives you an idea of the number of COVID patients at the various hospitals in our community. At the snapshot in time when this data was collated, we had 98 COVID positive patients at St. Joe's out of a total of 240 in the county. And you can see that San Joaquin General, Adventist Lodi, and Dameron are also sharing a significant part of that burden here. And then again, you go down COVID plus ICU on ventilators, 27 at St. Joe's when this snapshot was taken yesterday, 27 at St. Joe's out of 50 in the county. And that certainly tracks well with our own experience, where we have just an extraordinary number of very, very sick patients requiring extreme measures to prolong their lives. Next slide, please. So I'm going to get into some of our data on mortality outcomes thus far. We've been able to put together a pretty powerful series of data by looking at our mortalities and looking at what these patients are like. But I want to talk just a little bit about some conclusions that we can draw based even on our own experience, and this is completely consistent with the literature that's out there. You know, the first thing that I want to say is that this is not, you know, a bad case of influenza. This is an extraordinarily complex and severe illness, which is really wreaking havoc on communities throughout our country. And we're one of those communities. Your neighbors, your friends, your relatives are being impacted by this. And the disease is an extraordinarily severe one, causing exceptionally high mortality rates. Now, we do know that there is a decent amount of asymptomatic spread of the disease. And so there is a vast, vast range of presentation. There are a number of people who truly are asymptomatic and never develop clinical disease. And then we have a percentage of patients who have really some of the most severe disease that any of us in critical care medicine have ever seen. Amongst patients with symptoms, over 80% of them still have relatively mild disease and probably don't need to be hospitalized. But a certain percentage of those will develop severe disease, and we define that as somebody who needs oxygen treatment. And then about 5% will develop critical illness, meaning that they need some sort of high-level life support, such as a ventilator, dialysis, or other types of extreme support to prolong life. And then the mortality rate for those patients who are actually symptomatic is probably somewhere above 2%, although we are still sorting that out right now, but that's certainly consistent with our own data. As most of you have probably heard, age and comorbidities contribute greatly to mortality, with hypertension, diabetes, and obesity being the most significant risk factors, but cancer, chronic lung disease, and heart disease also impacting outcomes for these patients. Those people suffering from these chronic conditions have vastly higher mortality rates than do otherwise healthy folks. Next slide, please. So this again shows our own dispositions. This was updated on the 20th or through the 20th, showing that we discharged 216 patients home, 48 to skilled nursing facilities, a smattering to other dispositions. And then at that time, we had 63 mortalities. Just to give you an idea of what's happening with mortality, we've had, by my count now, 15 in the last 3 days. Next slide, please. So this shows the age distribution for our mortalities, and based on our hospitalized patients, we've had an 18% mortality rate thus far. And that's fairly consistent with the national numbers that have been promoted. In fact, our mortality rate may be a slight bit better than some of the data that we saw, for example, coming out of New York and other East Coast population centers. Almost all of those mortalities are for people above the age of 50, although we have had a few younger patients with very severe disease who have passed away as well. We have a significant predominance of men amongst our mortalities. For hospitalized patients at St. Joe's, the breakdown has been 50-50, men and women. But for mortalities, far more men have died than women due to the disease. And we don't know why that is. It's simply something that we've observed. Next slide, please. This shows the mortalities by month. And so you can see what I was talking about earlier. As we continue to see more and more cases, those patients having gone down the usual clinical pathway of a week or two to develop more severe disease, start to show up a few weeks after their diagnosis, unfortunately in the mortality category. And that number for July is now over 40. So an accelerating rate of mortality, very much in step with the increasing number of cases that we are seeing in the county. Next slide, please. Breakdown of race and ethnicity, again, this time for mortalities. Again, tracking our community fairly closely, although while about 45% of our patients have been Hispanic, only 37% of our mortalities have been people identifying as Hispanic for ethnicity. Next slide, please. And a few patient factors, things that I've talked about before. I'm going to just note on this slide that 71% of the mortalities that we've seen have been people coming from home. So this is certainly something that heavily impacts older patients who live in skilled nursing facilities. But in terms of absolute numbers, the significant majority of our patients who have died from COVID-19 have been people who've come from home in the community. Next slide, please. This slide just demonstrates that, as has been reported broadly, shortness of breath, low oxygen levels, and fever are very common in this patient population, with, in our experience, hypoxemia being the most common clinical finding. And then you can see that 63% of our mortalities have been patients with hypertension. That's a fairly extraordinary linkage. And we've also had a high number of our mortalities represent people with diabetes and obesity, as well as kidney disease. Again, very consistent with what's been reported nationally. Next slide, please. We have been able to treat a number of our patients with some of the experimental treatments out there, and I'm going to give you some data on those. The most common treatment that we've been able to give is convalescent plasma. We've been able to treat a few of our patients also with remdesivir, and then increasingly all of our patients are getting a drug called dexamethasone, which I'll review in my next few slides. Next slide, please. So this is the data that's been published regarding remdesivir. We're all looking for a magic bullet here, and so there's a lot of hope with regards to remdesivir and its activity against the disease. I hate to kind of throw a lot of cold water on that hope, but the data that's been reported in the New England Journal of Medicine in this particular instance, and our own findings are that while remdesivir may be somewhat beneficial in patients who are kind of in the middle range of disease severity, it does not improve outcomes in our most severely ill patients, and that's very unfortunate. What you can see in this graph is that people who present with mild disease, in other words, do not require oxygen, don't seem to really benefit from remdesivir. The curves, which in this case it's showing mortality rates, the curves are very similar for remdesivir and placebo. When patients do not need oxygen. When they need oxygen, in other words, they present in that sort of middle ground where they need oxygen, there does seem to be a difference, and there may be a survival benefit for these sort of moderately ill patients. But in the most severely ill patients, which you can see in the last two graphs at the bottom of this slide, there really is no difference in the curves, and remdesivir does not seem to have an impact on patients presenting with very severe disease. And our use of the drug, which is still very limited in quantity, reflects this pattern now. We're restricting it to patients who are presenting with a need for oxygen, but due to the fact that it has not been shown to be beneficial for mechanically ventilated patients, our most severely ill patients, we're not using it in that patient population, according to our protocol, which is consistent with national guidelines. Next slide, please. The drug that actually at the present time holds out the most hope is a drug called dexamethasone. And dexamethasone is a corticosteroid treatment, very similar to prednisone, although a more potent drug than prednisone. And in a very large trial that's been published in England, there was clearly a survival benefit for dexamethasone. And that survival benefit was seen mostly in the more ill patients. So unlike remdesivir, dexamethasone actually seems to benefit our most severely ill patients, and we've adopted its use for really all of our patients who require oxygen or more extensive treatment. Next slide, please. And then convalescent plasma is a product made from the blood of patients who've recovered from COVID-19. It's rich in antibodies against the virus, and the theory is that giving that infusion of antibodies against the virus will help the patient to recover more quickly. We don't know if that's actually true or not, and the brief reports that have been published are somewhat in conflict regarding the benefit of the treatment. We're participating in the Mayo Clinic convalescent plasma study at St. Joe's, and so all of our patients are being enrolled in that study when they get convalescent plasma. We've treated 190 people to date. There have been 30 mortalities in the treatment group, but we really won't know whether convalescent plasma saved lives until we get that very large study from the Mayo Clinic that we're actually participating in. Next slide, please. So we have gradually ramped up our testing capacity at St. Joe's. And what you see here in the top right is a machine called an Abbott M2000. It can perform about 400 COVID tests a day. We had one of those machines to begin with. We've just obtained another one. And so our capacity has increased to nearly 1,000 tests per day. Now that probably sounds like an extraordinary number of tests, but you can't do that many tests if you don't have all of the reagents and preparatory material that's necessary to run the test. And so we're not quite there yet because some of those materials are actually in limited supply. We're limiting our testing right now to a specific group of folks, those who are going to most benefit from the test result. That means our inpatients. That means people who are undergoing procedures. That means people who need placement at skilled nursing facilities or psychiatric facilities where they're requiring a test before we can discharge the patient there. We certainly like to be doing broader testing, but the kind of numbers that are needed to do, for example, community-wide testing are another order of magnitude greater than what we've got. We have probably some of the most robust testing of any hospital in Northern California, and that testing capacity is being essentially completely exhausted right now, just with the demand for inpatient testing and testing of patients who have other specific requirements for getting a test done, either because of a procedure or a placement issue.
And I just want to mention, Scott, if it's okay, that on the testing,
Yeah.
Our laboratory here in Stockton has been the reference lab for the Dignity Health hospitals, 39 acute care hospitals in 3 states. And we are receiving hundreds of specimens a day from other hospitals in other markets, Los Angeles, Northern California, the Bay Area, and we are receiving tests from San Joaquin General and Dameron Hospital as well. So we're trying to do our best to meet that demand, and even with that, we're restricting our own testing to a degree on patients. We're hoping as we add this second piece of equipment, we'll be able to test more of our patients who are admitted to the hospital for other things like obstetrics or people who are maybe asymptomatic and we're not testing now who are admitted to the hospital. So it's very hard to try to figure out with 1,000 tests a day how to actually help our community, but we're doing so in trying to make the hospital a safer place and trying to make other hospitals, both in our community and in Dignity Health, safer.
Thank you. Appreciate that background. So I want to touch briefly on this, but I do want to emphasize the impact that this has had on the families of patients as well as the patients. This disease is affecting an extraordinary number of people, and unfortunately, a large number of them are becoming severely ill. The safety measures that we're required to observe in order to safely take care of these people, and also in order to keep our staff safe and our physicians safe, our other employees who interact with patients as well, has very much limited people's ability to actually be with their loved ones while they're ill. And so it's the double impact of a disease that's horrific in many cases, and also separates us from our loved ones at their time of need. And I meet with families almost daily to talk about their loved ones and the care they're getting. And I can't say enough about the impact of this on people whose loved ones are ill with the disease. We've been able to ameliorate that impact somewhat with the use of technology, being able to take iPads and iPhones and so forth into the rooms, and let people hear their loved ones' voices and see them, see what they're going through with some of this very invasive treatment that's required to save their lives. We've also been relying heavily on our palliative care practitioners, people who assist families and assist patients who are unfortunately in the process of dying, trying to make sure that we're ameliorating their suffering, that they get a chance to say goodbye, and that they get a chance to communicate with the people they love. It's just been incredible in terms of the human impact, and I know that's something that we will be experiencing and living with for a very long time. Through all that, we are so proud of our staff, our physicians, our providers, our therapists, our nurses who have cared for these people, because the feedback that we're getting is that people who come to us have been extraordinarily grateful for not only the technical quality of care, but the fact that we treat people with love and compassion when they're going through this. And that's been reflected in our feedback and our patient experience scores. And these numbers are meaningful. We like to look at them, but I think the stories that we get from the patients about the dedication and the loving care that they've gotten from our staff has been something that has lifted us up when we know that people are going through some very, very difficult times. Next slide, please. I want to talk a little bit about the community impact beyond COVID, because when people stopped coming to the hospital because they were afraid to come to the hospital, other types of harm started to occur. And what we know now is that in March, in many parts of the country, including here in San Joaquin County, we started to see an increased risk of deaths that was not accounted for by COVID. And you can see this in a graphic from the Washington Post. But there was initially some fear that we were underreporting COVID, which is probably the case, actually. But just as importantly, what was happening is that people were not seeking care when they had acutely reversible conditions, and they were dying as a result of it. Next slide, please. So in San Joaquin County, and this is some data that was put together by our colleagues this was some data that was put together by our colleagues at Lodi Memorial. In March versus February, we saw a very sharp increase in out-of-hospital cardiac arrests. And what that probably represented is people who were symptomatic, who were short of breath or having chest pain or other symptoms at home, who were afraid to go to the hospital because of the pandemic and ended up having cardiac arrest at home. Had they come to the hospital, we would have an opportunity to treat their reversible condition before they actually had the cardiac arrest. And we believe that patients have been harmed due to a lack of acute care for myocardial infarction or heart attack. We believe that patients were harmed as a result of staying home when they had a stroke that could have been treated in the emergency department. And we also think that patients who delayed care due to severe infection, cancer care, surgical care, and even outpatient treatment may well have been harmed as a result of the changes in the patterns of care that we were delivering when the pandemic first hit us. And as a result of that, we really developed a philosophy of figuring out how to treat everyone, how to stay safe together, and to make sure that all of us are getting the care that we need. Next slide, please. And this is just another recounting of that particular information from one of the Harvard hospitals in Boston. Next slide, please. So, to sum it all up, we've gone through quite an extraordinary experience as clinicians and nurses, therapists, and other types of frontline staff at our hospital. It's required a great deal of flexibility, of adaptability, of change. We have been taking care of hundreds of patients with a very severe and in many instances catastrophic form of disease and presentation. And we've done so with a level of skill that makes us really proud of all of the people that we work with here. But we have a lot more to do. An important part of that is staying safe together. Politicizing a healthcare catastrophe is a grave mistake. This is scientific fact. The distancing measures, which include things like hand hygiene, physical distancing, avoiding crowds, and wearing a mask, can save hundreds of thousands of lives going forward. The analytics shop at the University of Washington that has been relied on by the administration, by the federal administration, in making projections, has suggested that the difference between people essentially wearing masks and not wearing masks could represent 200,000 mortalities by the end of the year. And so this is a matter of life and death. We have to stay safe together. We have to continue to slow the rate of disease, both to save people's lives until some sort of a treatment or a vaccine is available, and to preserve the functionality of our healthcare system. If we're overwhelmed by a continuing rise in the number of cases, then nobody's going to get good care. So it's critically important that we continue our efforts to flatten the curve and to slow the rate of disease spread in order to make sure that all of us can get the care that we need. That's our approach at St. Joe's. We're taking care of COVID-19 patients with as much skill as we can muster, but we're also working really hard to steward our resources so that we can take care of people who are having heart attacks, so that we can take care of people with cancer and other types of severe illness, people who still need to be taken care of and still need resources. Staying safe together means conserving those resources and having them for all of us in our community when we most need it. I'm gonna stop now. I've used up perhaps too much of my time, but we want to have some time for questions. So thank you, Don.
Thank you very much, Scott. It's 1 o'clock. We still have 340 people on the call. Dr. Park and Dr. Neeley, are you guys willing to answer some questions?
Yes.
Yes.
Okay, Natalie, why don't you lead off with the questions, unless you want me to do so.
No, I'm going to address the ones that were submitted in advance. And then if we have time, we can go to a couple that were submitted via the chat. The first one, and this is probably for Don, is what is your turnaround time for getting test results?
So one piece of equipment we have where we're doing about 60 tests a day, primarily for patients being admitted from the ER, is a two-hour turnaround time. The other piece of equipment that we're currently doing about 387 tests per platform per day has a 6-hour turnaround time. We're able to do essentially 94 tests per run on that machine. But once you start the run, you have to wait for the results. It takes about an hour and a half to set up and about 4 hours to run. So in our case, that's the turnaround time. For our hospitals who are doing preoperative testing, as an example, we basically can do a 2-day turnaround time. Now, most of this testing that I'm talking about is the testing necessary to be able to safely run the hospital or to support other hospitals that want to test patients for either procedures or for admitting them to the hospital, knowing whether they're positive, knowing if they need to be isolated. It's not really that available for the community. Our understanding from other hospitals who would like to use us is that other hospitals are having turnaround time when they send a test out of 6 to 7 days.
Thank you. There's another question that says, if an individual tests positive for COVID, when is it acceptable for them to return to work?
Maggie, you want to take that one?
Well, in general, they are able to return to work once they are cleared from isolation. So we use a symptom-based strategy for clearing from isolation. And now as we get inundated with so many positives, we actually think that the public can clear themselves in a way if they understand the rules. So it's 10 days from the time you started having symptoms to the point where you can be cleared, as long as the 10 days includes 1 day of being symptom-free at the end with no fever, without using any antipyretics. So it was called the 10+3 rule, 10 days including 72 hours of being fever-free. But now, just recently, the CDC has changed it to 10+1. So 10 days plus 1 day within the 10 days of being symptom-free, or if it takes an additional day or two to get there, it could be more than 10 days. That is the scientific rule, but I know that some workplaces are asking for more than that. A lot of doctors are still using 14 days before they'll clear people. So it kind of depends across the board, but the CDC and the California Department of Public Health is using the symptom-based strategy of 10+1.
Thank you.
And for those of you on the call, there's a little bit of a why there. There's a couple of reasons not to retest people. One, we don't have enough tests, period. So every time we order retesting, we're using a test that somebody else could use that might be more clinically important. The other thing is that we know now from studying the disease that the ability to infect other people is greatest at the onset of the illness and wanes pretty significantly by the time the patient's fevers go away. And therefore, even if we test them and they're still positive, it probably doesn't necessarily mean that they're shedding a lot of virus or particularly infectious. And so there actually is a logic behind the recommendation that Dr. Park described. And we're still at a point in terms of our testing capacity that over-testing people by doing a bunch of tests at the end of the illness doesn't necessarily make sense or serve the community.
Thank you. This question says, why are dental offices who use high-speed tools and are directly in the mouths of patients where aerosols are being emitted not mandated to follow proper guidelines, and can this lead to exposure? I think it's referring to masking.
So they do have guidelines put out by the California Dental Association. The California Department of Public Health did allow dentist offices to reopen back in early May, following some of their own guidelines. And dentists were actually really asked to make sure they had 2 weeks worth of PPE and to follow their local case counts before they decided to open up. So there were some recommendations made. I have heard some disappointing stories about dentists who are not being as careful as they could be, but there are guidelines out there.
Okay. The next question is, why are some stores not enforcing the mask rule?
I don't know. I wish I knew, and I wish they would all enforce it. You know, it's a law now in California that you wear your mask. And so we have to try to get on top of those stores and some restaurants and places where masking is not being strongly encouraged. We get emails all the time here at Public Health from the public letting us know that they've been somewhere where masking wasn't being done, and that's unfortunate. So continue to let us know. The county is working on setting up a specific email address for you to report violators to us, because we're trying to get on top of all of this. So I really don't have an answer for that, but I do want to make a plug again for our Mask On campaign and thank Mr. Wiley for really supporting that. And we really appreciate the support from Dignity Health. It has just launched as of this week, and literally you're going to be seeing many faces of people wearing their masks, and it says on the mask who they're wearing it for. So hopefully you look out for that, and hopefully it increases the number of people who mask on.
Thank you, Dr. Park.
Thank you. This one says, cases per capita in San Joaquin County have recently been very high, even higher on some days than Los Angeles County. Is it preferable that all San Joaquin County residents who are infected stay in San Joaquin County for treatment?
Well,
I'll take that one. I mean, if you live in San Joaquin County and you don't need to be hospitalized and you develop COVID-19, you need to follow public health guidelines for avoiding spreading the disease to other people. And you can do that in San Joaquin County, and you can do that, you know, in another location if it's more convenient in terms of the activities of daily living that you need while you're self-quarantining. In terms of if you're sick enough to be hospitalized, at the present time, we have resources in San Joaquin County to take care of our patients. But those resources are being pushed. And if things do get more severe, we're likely going to be looking at transferring patients out of the county to medical centers in areas where they're not as hard hit. We are prepared for that. We hope it doesn't happen, but that would be sort of the next step in terms of escalation once we exhaust our own capacity.
Thank you. This says, and this is probably for Don, could there be modification of hospital rooms to provide additional intensive care service even if it exceeds the licensed capacity?
Short answer is yes, and we're actually doing that. We have a telemetry or a medical surgical telemetry unit right outside of one of our ICUs, and we have created 9 additional ICU beds in that unit that have the proper equipment to run them as full-fledged ICUs. And we have been doing that. We actually started doing that in early April to practice, thinking that we might get busier at that time. Of course, we didn't. And then when we were glad that we had practiced and that we had figured out what the issues might be in those rooms. And we're now operating 9 additional rooms on what we call 4 East.
For Don, can St. Joseph's use the federal military medical teams that Dameron and Lodi Memorial are using?
You know, the political answer is yes, we could use them, but the actual answer is no, we weren't offered them. So as I understand it, and this was presented to us on last Thursday's EMS call, which I think is going on right now, that the federal government and then through the state identified hospitals that had either impact to their staffing. In the case of Lodi Memorial, they had an outbreak in their staff, and that they had bed capacity. And so both Dameron Hospital and Lodi Memorial are operating less than 50% of their licensed bed capacity, as opposed to San Joaquin General Hospital is actually currently operating, I think, more than 100% of its bed capacity. And St. Joseph's is operating somewhere in the 80s. When we're operating in the 80s, we're very close to capacity because we have so many 2-bedrooms and specialized beds. So again, the short answer is we could use the help. I'm going to be on a call in a little while where I'll be talking to the people from CMS, and the federal government, I'm sure, is here to help us, and I'm sure they're going to give us a bunch of staffing and other things. And I'm being facetious, but we will ask for that the same way that we asked EMS if there is any available staffing from the state or federal government we would like to be considered. And we continue to source staff from other sources as well.
Is there a possibility of transporting some patients to Sleep Train Arena in Sacramento?
It's my understanding that that's not going to be reopened, at least at this point. It's not being considered, and the same is true of some of the other sites in Southern California and the Mercy Ship. All of that capacity that was created in March and April went underutilized, and the state is reluctant to invest a second time in those sites based upon that first experience. That's my understanding from being on the calls.
Don, those are all the questions that were submitted in advance. There are some that came up through the chat. We are over time, so it's at your discretion.
How many people are still on the call?
290.
Is it okay if we go for, say, another 7 minutes?
Sure.
All right. Would you like me to sort through the questions?
Yes, please.
All right, I'll do that.
While you're doing that, one of them said, is asthma considered a precondition? Dr. Neeley?
Yes, it is. It increases the risk for severe pulmonary disease.
Dr. Neeley, what percentage of those patients that have been put on a ventilator survive or recover?
In our experience, less than half.
Are there any studies that show that there's immunity if you have antibodies or if you've been previously exposed or survived a COVID illness?
So there's a lot of studies going on, and there are some studies already on that issue. And they go both ways. There are some studies that say you have no immunity from antibodies and some that say you'll be immune for a few months. So time will tell as research is done. The general belief is that if you've had COVID and You've developed some antibodies that you might have some short-term immunity at least, but there's no definitive answer yet.
All right. There's a question, if someone tests positive but they're asymptomatic, how long before it's safe for them to go back out into the community?
Oh, so again, it's the 10+1 rule to clear yourself from isolation. 10 days from the onset of symptoms, as long as 1 day has been included that you've been fever-free and symptom-free.
And then when they go out in the community, what are they supposed to do? Wear a mask. Okay. Sorry.
Keep your distance, wash your hands. We'll keep saying that until people get sick of us saying it, but yes.
I've got like 10 masks in my office, all different sizes and shapes and colors and quality. None of them are very comfortable to wear for very long. Let's see. I think there were a couple of other questions that were particularly good. There's a lot of questions about more testing sites generally, and Dr. Park, this is really for you, but you know, what can and should we expect either from county or city or the state in terms of offering more testing sites for individuals who would like to be tested?
Right. So I'm reading all of the posts about how there's such a delay in getting a testing appointment and then getting your results. So the sicker we got, the more the demand was for tests, and then the longer it took to actually get a test, which is why then Dr. Galley created a testing prioritization tiered approach to who can get prioritized, and obviously hospitalized people get that priority. But we do realize that we need to increase testing capacity, because until we can test everyone who wants to be tested, we can't really successfully isolate them and get transmission down. So the county is working on this, and I don't know how successful we'll be, but I think we'll have something for sure. We're looking at possibly even some mobile testing strategies so that we can move through the county and be available to different test sites or different sites in general. And I'm looking into a couple of companies that might be able to offer more test collection kits, because those are in limited number, but there are some companies that have them and will sell them to you and then run the test for you. And we just need the clinicians to actually do the testing. So that's something that we're really looking into right now. So more to come.
Thank you, Dr. Park. The other thing I would say, you said as we got sicker, so as we went into the last week of June and the first week of July, we actually, monitored our test volume, because we went from basically being able to promise everybody who had been using us for testing a 48-hour turnaround time for their pre-op patients and all their testing. And by the time we got into the first week of July, we were receiving 175 more tests per day than we could produce, just from hospitals and in our market and outside of our market who were sending us requests for testing. So the testing has gotten very tight. And when we told hospitals it would take 4 days to turn their test around, they said, well, that's better than we can get anywhere else. And these are acute care hospitals trying to take care of emergency patients. So testing has gotten very tight, and so this issue isn't isolated to San Joaquin County. In some ways, we're better off than a lot of other places.
Right, and like you, public health is trying to buy more machines. So we've put in for one, and there's so much demand for the machines that are actually used in the lab that we might not get it till the end of September. But we did get a new Kingfisher just yesterday, which will help with the RNA extraction part to prep the test. And that actually triples our ability to test. So we were able to do about 120 tests per day, but we literally just tripled that. It took a lot of work from our lab to even get caught up in the first place. We had a lot of samples in our freezer, to be honest with you, because it was just getting overwhelming. But we've caught up through a lot of hard work, and we have the capability to do more. Certainly not as much as St. Joseph's is doing in your lab, but we're trying to increase our capacity on this end as well.
Natalie, anything else that you see? I think we're right at the time that I promised.
I think we are too. I just want you to remind everyone, or I can remind everyone, that this meeting was recorded. We asked for, there were a lot of questions about sharing slides, which we won't be doing, but we will share the recording for this meeting. It will be on our website, stjosephscares.org, and we will also push it out via social media.
Thank you everyone for being on. Thank you, Dr. Park and Dr. Neeley, for your medical expertise. I know that I enjoyed it, and I'm certain that our community did. I appreciate all that you're both doing for our community. Thank you.
Thank you.